I just wanted to thank all the attendees for coming, and of course, thank Lauren Diamond Brown. We're very excited about hearing her talk. And just a reminder that you can view all the presentations after the end of at the end of the conference. So if there's one that you didn't get to see, you'll be able to view it. During the presentation, you can type any answers into the Q&A session. I actually tried that with the first presenter and it didn't work. But the chat works. So if your Q&A doesn't work, I know that Lauren will be able to see the chat as well. We'd like to welcome Lauren Diamond Brown. She's an assistant professor of sociology at SUNY Potsdam, where she teaches a course about reproductive justice. She has published research on obstetric decision-making in birth, as well as about women's experience with unassisted birth. And unassisted birth is birth at home with no, I should have, this page is stuck, sorry, with no attendant. Her current project seeks to understand people's experience of pregnancy, birth, and postpartum, where she lives in St. Lawrence County, New York, so she can educate her community on their rights to quality care and work with community partners to improve perinatal care. And thank you, Lauren.
Thanks for that introduction, Connie. So I'm going to go ahead and share my screen and get started. Okay, so the topic I'm going to be talking about today is understanding obstetric decision-making in hospital birth. And, as Connie said, I've studied a number of different aspects of reproductive justice. And today, this is going to be based on research that's really looking from the obstetrician's perspective in hospital birth in the United States to better understand what's going on when they're making clinical decisions. And with a special attention to issues of reproductive justice like autonomy and rights of the patient and so on. So the study methods that I'm going to be basing my talk on, this was an in-depth interview project with 50 obstetrician gynecologists working in hospitals in 3 states in the United States, Massachusetts, Vermont, and Louisiana. These are states that have very different contexts of practice, different environments, different sort of statistics on fetal and maternal health outcomes. So it captures kind of a wide perspective of clinical environments where OBs might be practicing across the United States. And these interviews were conducted between 2013 and 2015. So before I start getting into my data specifically, I want to just give some context to the environment where obstetricians are making decisions, clinical decisions in labor and delivery. So I'm going to just touch on a few different topics. One is medical uncertainty and practice variation in labor and delivery. Another is practice settings in the United States. And also forms of knowledge that obstetricians use in their clinical decision-making. So in labor and delivery, there is high medical uncertainty, meaning that the obstetricians that I talk to explain that there's actually a lot of clinical moments where there isn't one obvious decision that they should make to lead to the best health outcomes, that they don't always have great evidence for a lot of the clinical care decisions that they make in labor and delivery, that a lot of people don't want to sign up for clinical trials when they're pregnant. So they lack evidence to make decisions on. So one thing to just keep in mind is that often doctors kind of talked about labor and delivery as these places where they don't always know what the right thing to do is. It's not super obvious from a medical perspective. This relates to the fact that there is very wide practice variation in obstetric knowledge. And in addition to medical uncertainty, there's what I would call unsettled authoritative knowledge in the field of how we approach taking care of people in labor and birth. So in the United States context, there is sort of a competition between the obstetric model of care and a midwifery model of care, where there are a number of different perspectives and opinions on how best care should be done. And even just within obstetrics, obstetricians don't agree on the best practices. So there is great variability just within obstetrics in philosophy of birth, how they think about birth. This includes some of the obstetricians that I spoke with having a very, what, for instance, Robbie Davis Floyd would have called technocratic model of birth, the quicker the better, high use of interventions, birth being understood as a dangerous medical event. We got to do as much as we can and get that baby out as quickly as possible. Versus a more midwifery, philosophy of care, or a physiologic model of understanding birth, where it's understood to be a normal and natural physiological event that can often happen in a low-risk patient without much medical intervention. And interventions are really only to be used when there is a problem. So within obstetrics itself, there's this wide variation of philosophy of sort of how a doctor thinks about birth. And that relates then to their style of practice. Do they use, for instance, is it routine for them to cut episiotomies? Is it routine for them to leave a very limited amount of time before going to cesarean? Do they induce all of their patients, right? Like these kinds of styles varied quite a bit. And even the particular skills that OBs have. So some of the obstetricians I talked to, for instance, have not been trained to use forceps since their residency, which might have been 20 years ago, and they never use them. So if it's a difficult vaginal delivery, they wouldn't have that skill set to even potentially try to use a forceps. They might go straight to cesarean section. Or some obstetricians are skilled in breech delivery, or some are skilled in twins, where the first one is head first, but the second one is breech. And, they've been trained on that and they feel comfortable with that. Others would say, absolutely not. I've never been trained. I don't have those skills. So great practice variation in obstetrics. The other sort of contextual piece here is practice settings in the United States have become increasingly fragmented, or producing fragmented care. So it used to be, 40 years ago, that most obstetricians had solo private practices where, they met their patients in pregnancy and they were on call for their patient's birth. That's really changed. The majority of obstetricians today work in group practices where doctors rotate call shifts in labor and delivery. So they're scheduled to be on call for their group. If any of their patients go into the hospital to have their baby, whoever is on call is the one that's going to take care of them. So what this means is the doctor-patient relationship becomes fragmented as opposed to continuous. And a lot of the obstetricians I talked with, when they were talking about clinical decisions, were caring for patients that they had never met prior to meeting them in labor in the context of their call shift in the hospital. And the last contextual piece has to do with something I'm going to dive a lot deeper into here, which is what forms of knowledge do obstetricians base their decisions on? Okay, so I've kind of painted a picture of the context in which they're making these clinical decisions. Well, what are their decisions actually based on? And I found in my research that there were 3 primary forms of knowledge that doctors talked about making decisions based on: clinical experience, standards of care, and patient-centered care. And I'm going to give a little breakdown on what each of these mean, and then I'll talk about how they are actually used in practice. And that's going to be a lot of what I end up talking about today. So clinical experience is kind of the default knowledge base for most obstetricians. This is their experiential knowledge that they gained as a doctor through their training and through their years of practice. So kind of their hands-on experiential knowledge, how they were trained, what they've seen as they've been practicing medicine. This encompasses their philosophy of birth and their skills. So if you remember, I talked about there being quite a lot of variation of philosophy and style and skills. All of that is kind of contained under this category of relying on their clinical experience to make a decision. Another form of knowledge that emerged in many interviews, excuse me, some water. Are standards of care. So this is the idea, or really a growing expectation in medicine more broadly, that doctors will make decisions on standardized forms of knowledge, such as evidence-based research, professional guidelines, and protocols. So as opposed to relying on one's own clinical experience, which might be quite limited, maybe you've only seen one kind of patient in your entire practice, you don't really have a public health perspective on what do the numbers look like when we have large studies, and we can standardize forms of knowledge through evidence-based research, right? So there's a growing trend in lots of fields of medicine, including in obstetrics and gynecology, to expect that doctors are going to use evidence-based research for their decisions. Now, if you remember, I said there isn't a ton of evidence-based research in obstetrics and gynecology, or obstetrics, specifically labor and delivery. But there are professional guidelines. So ACOG, which is the largest national organization for obstetrician gynecologists in the United States, they do publish practice guidelines and protocols, which are often a set of recommendations based on consensus, not necessarily evidence-based research, more like committee opinion consensus on practice guidelines. And then there are also protocols that might come through specific hospitals or even insurance policies or state laws, these kind of things. So this is one piece of knowledge that doctors are relying on to make decisions. And the last one is patient-centered care, which again is another rising expectation in healthcare more broadly, that both patients are going to be able to participate in the decision-making process about clinical care decisions, and also that those decisions are going to be based on the patient's values and their individual circumstances. So, although this is understood as sort of current best practices, this is really more talk than change, based on what I've seen in my research and also what a lot of research on this topic has found. There does appear to be quite a lot of variation among obstetricians, and other research has shown across other medical specialties of doctors who have a more paternalistic, which would be more sort of authoritarian, they're in control of the decision-making style, compared to a more shared decision-making style where they're inviting the patient to share in that decision-making process. But like I said, a lot of studies kind of cast out whether these knowledge and power asymmetries between a physician and patient can really be remedied through this pressure on physicians to practice patient-centered care. And a lot of what I'm going to dive into today has to do with this very concept of how patient-centered care really kind of plays out in practice or doesn't. So the question that's going to sort of guide the rest of my talk, now that I've gone through a lot of the contextual background information, are how are these forms of knowledge actually used in practice? And what I discovered is that there's a number of important challenges to patient-centered care and action. And the first one I'm going to talk about has to do with the way that care is organized in this fragmented care relationship that I had mentioned. So patient-centered care, right? This idea that decisions are going to be based on the values and life circumstances of the patient, that requires trust between doctor and patient and time spent together, right? You have to spend some time getting to know a patient as a physician to understand their values, to understand their life circumstances that might be affecting how you would make clinical decisions about their care and birth. But because most obstetricians don't have continuity of care through pregnancy and labor and delivery, what I found was that in fragmented care, when doctors are meeting patients for the first time, when they walk in to meet them in the middle of their labor, this can lead to decisions being made on superficial and stereotyped information. And this is really problematic because it risks the reproduction of inequality. So this is especially problematic for patients who are already coming from a marginalized population, where the doctor can then make stereotyped judgments on that patient that further marginalize the care that they're getting in their labor and delivery. So let me give you a couple examples of narratives from my interviews that help illustrate this idea. So the first one comes from a doctor who's talking about how he tries to use patient-centered care, information about the patient, to make decisions on when he recommends a C-section. So he says, we have two extremes of kinds of patients here. The culture in Brazil is that a cesarean is the way to go. People have elective cesareans all the time, the ones who can afford it. They certainly don't have a negative connotation for it. And then the other extreme of patients we have here, these would be patients who emerge from our midwifery practice. These people have sometimes come up in life fearing cesarean like it's the plague. So if I'm dealing with an issue in labor and I have the first type of patient who's actually, asking for a cesarean the first time they feel pain, if something does happen to slip off the straight and narrow with that lady, I'm going to be quicker to wheel her to the back and do a cesarean. If I have somebody else who's fighting us tooth and nail about it, I'm kind of more likely to stick my neck out and help her have the kind of birth she wants to have. So here, the idea is that he's going to be making decisions about how quickly to do a cesarean or how long to wait for labor before doing a cesarean. And he's doing it on a judgment call of whether, this person is Brazilian or if they came from their midwifery practice. So, the choice to have a C-section isn't clear cut, right? It's open to the influence of values. And that can be really great if the doctor accurately understands the patient's values. But in fragmented care, right, there's these structural barriers that can get in the way of them effectively knowing their patients. So this kind of use of superficial first impressions of patients also emerged when doctors were talking about the level of decision-making that they sort of expected or invited their patients to share with them. So let me offer another quote to illustrate this point. Well-educated middle and upper class are maybe a little more willing to listen to the primary evidence about, is this good or bad? For my less economically privileged patients, less educationally privileged patients who tend to have a Hispanic background, it's much more, well, doctor, if you think it's a good idea, I'll do it. And then from my African-American patients, I get more of a, are you sure? Really kind of more of a skepticism. So, this kind of stereotyping raises concerns, again, about the reproduction of inequality. And these challenges are exacerbated when the sociocultural divide between doctor and patient are wide. And when I would sort of push doctors in asking questions about this, they kind of just were like, well, there's only so much we can do, right? Like they literally might have 2 minutes to talk to someone in the middle of the labor when they feel like they have to make a decision about something. And they're trying to very quickly pick up whatever they can about this person to inform their decision. So when I was asking about these challenges, one doctor says, there are many cultural factors that you cannot and do not have time to enter into as you walk into those settings. You may never unpack. and you're going to carry them and they're going to carry them. And, you know, my job in that setting is to make sure everyone is safe. So I think when we're thinking about reproductive justice and many of the themes in this conference around empowerment and autonomy and patient rights, many of the OBGYNs that I spoke with had a very narrow concept of patient safety is what matters. And at the end of my talk, you know, I'll list some recommendations of how to improve hospital birth. And one of them is to expand our definition of safety to include sociocultural psychosafety as well. Okay, so another challenge that emerged in my data about actually using patient-centered care in action had to do, again, with the shift model of work. But this was about when there was a shift change in the hospital and one obstetrician had to sort of hand off a patient to another obstetrician. And this caused conflict sometimes conflict between the doctor and the patient, and sometimes conflict between the doctor and their colleagues. And again, this has to do with fragmented care relationships where, you know, sometimes a doctor would say there might be 2 or 3 different obstetricians who have call shifts throughout one person's birth. So, you know, birth can last a long time. Call shifts might be 12 hours long. It's quite reasonable to expect that a single patient's labor, they might see 3 different doctors, 3 different OBs during that labor. And what happens if they have different philosophies of birth, styles, or skills? So this is something that that emerged as a problem for the OBGYNs. Some of them talked about, you know, disagreeing with doctors on a shift change, about how care had been managed for a patient. Some doctors spoke about, quote, cleaning up messes from other doctors. And I have a specific scenario to illustrate this. So this was a doctor talking about a situation where the question was how to deliver twins when the first baby was head down and the second is breech. So this is an area where doctors said there's a lack of scientific evidence and great variation in professional opinion and clinical skill. So the doctor explained what happened in one of these situations. It can be problematic for a patient who's been on call and someone says, yeah, I'll do it for you, I'll do it. Meaning they're referring to approaching the birth, planning on doing a vaginal delivery of twins in this situation. And then the shift ends and somebody else comes on and says no. Then that can be a big disappointment for the patient. It can be an unfortunate outcome for the patient. You know, truly, they would have ultimately had less pain and less complications if they had a vaginal birth instead of a C-section. And that's, again, where the art can become a problem when people have different comforts and skills and there are no clear answers. So here we see the context of great variability in practice, a lack of standards for this particular clinical moment. So that patient, you know, the first doctor on call said, yeah, we'll do a vaginal delivery, no problem. And the patient was really happy about that. Then that doctor's shift ends. The next person comes on and says, no, I'm not doing it. We're doing a C-section. So, you know, this highlights the importance for a well-matched doctor-patient relationship if patient-centered care is something that we really want to have happen in labor and delivery, or any healthcare for that matter, right? But especially in labor and delivery, where there's great variability in practice on provider side, and there's also great variability in terms of what patients want, right? People have very different expectations and desires about what they want in birth. Okay, so I'm going to be moving on to talking about what I describe as a conditional approach to patient-centered and standardized decision-making. If you recall, the question I was asking is sort of, how do these different forms of knowledge actually play out in practice? And what I found was that obstetricians had a very conditional approach to whether they used patient-centered or standardized decision-making. That default clinical experience, that form of knowledge is sort of, again, always the default backbone for a lot of OBs. And then sometimes they integrate patient-centered care, and sometimes they integrate shared decision-making. But they definitely felt like they had the ultimate authority to decide when to integrate these other forms of knowledge. Standards were largely understood to be guidelines, not laws, that they could sort of interpret the usefulness of them when they thought it was appropriate. And patient-centered care, which largely based on their interpretation of patients, and especially sort of their judgment of patient worth, being a major factor in whether or not they were practicing patient-centered care. There are some other important contextual factors that sometimes influenced whether they were going to use patient-centered or standardized decision-making. And these were things like pressure from colleagues. So sometimes in a group practice setting, the doctors all agree on a particular group standard of care. So maybe they say as a group, hey, we all are not going to offer VBACs, vaginal births after cesareans. And even if there's one doctor in the group who kind of felt like, well, I'm actually comfortable and I want to be able to do that, they might agree to not offer that so that all the doctors could be on the same page. So sometimes when doctors were talking about a clinical decision, they would be like, oh, you know, if my colleagues knew that I was doing this, like they would get really mad at me, sort of language of kind of a group think, group pressure. Sometimes other health professionals influenced their decisions in the hospital context. That might be an anesthesiologist or a maternal fetal medicine specialist, right? Sometimes institutional needs drove decisions. So this could be something like needing the hospital bed or considering whether, you know, they wanted to call in their OR nursing staff if they were a rural hospital that didn't have that staff always sort of present in the hospital. And malpractice threat was one of the other big ones that was talked about, especially in regard to patient preferences. And I'll get into this a little bit more. But the idea that sometimes practicing patient-centered care was interpreted from the obstetrician's perspective as risky for them as the doctor. Not so much worried about the risk that that patient might be taking on for themselves or their child, but risky for the doctor to sort of go against standards or go against their clinical experience to honor what a patient wanted because of malpractice threat. Okay, so I want to give a couple examples of the conditionality of approaching patient-centered care from an obstetrician's point of view. So sometimes even within a single interview, I would have an obstetrician talk about certain cases where they followed patient preferences and certain cases where they didn't. So that's the kind of narrative I'm going to share with you now. So this is from a physician, an obstetrician, talking about when she would kind of go against standards or her own clinical experience to follow patient preference in care. And she says, yeah, anything that violates the CDC guidelines, the Center for Disease Control in the United States, that's out of the guidelines of the hospital, and I won't even care for those patients. We'll have some dialogue. Like I have a patient right now who is very young, seems very educated, but almost to a fault. Now I'm willing to sort of say, okay, do you know you're going out of the guidelines? And right now it doesn't matter, but later in pregnancy, you know, it will. So now if you say to me at the end of your pregnancy, you're going to refuse this, I can't care for you because I can't care for someone who won't do what the hospital requires. I won't bend the rules. So she has this very clear statement where she's grounding her refusal of patient choice in standards of care, right? I'm not going to practice patient-centered care because it goes directly against what the standards are, and I'm following the standards. But literally in the next breath, she says this, but I would for, say, a Jehovah's Witness. We have patients who are Jehovah's Witnesses, and I would feel it would make me very uncomfortable, but I would care for them because I believe they have a strong belief, and their ability to make that decision comes with a lot of education. I would absolutely think it's the stupidest thing in the world to die when all you need is a blood transfusion when you're having a baby, but I would still do it. So here she explains that, she will break the rules for certain patients. The young woman is framed as having an illegitimate set of preferences. And so the obstetrician is going to refuse her preferences, refuse to even be her physician. But she has the willingness to break the rules for Jehovah's Witness, whose perspective she just simply judges as more worthy. And so this kind of like flexible conditionality where sometimes they do what patients want and sometimes they don't really show how strong a physician's judgment of patient worth affects their clinical decision-making in labor and delivery. I'm not able to see the chat right now. So if there have been questions coming in, I apologize if I'm not answering them. But maybe just when I'm done talking, Connie can help me see. I think I just have to stop sharing the screen and I'll be able to see the questions and I'd be happy to go over.
Yes, that's it. You just have to stop sharing the screen, and you don't have to answer them until they're over anyway. That's the standard that we're going to do. So when you're all done, we'll just look at the chat.
Thanks for that clarification, Connie. Sounds good. So I'm interested in reproductive justice. So from this study, something that I was really looking to analyze was, why is it in some cases a patient's preferences are honored, their autonomy is honored, and in some cases they're not and they're violated. And we have these stories of obstetric, violence and trauma. So continuing to unpack this value of patient worth and sort of the philosophy that obstetricians are bringing to their practice, I want to center on this connection between patient-centered care and patient autonomy. And what I found was that analyzing obstetric philosophy, some of the obstetricians had a very high commitment to patient autonomy, and they felt like any action that was done to a woman in labor and delivery without her explicit and affirmative consent is an assault. They were the minority in my study. Other OBs and more of a majority of OBs view patient autonomy as something that they can sort of give the patient or not, and that it's something that can be violated when their own clinical experience or standards of care leads them to believe that the woman's making a bad decision. So if they don't agree with what the patient wants, if they think that it doesn't conform to their understanding of birth, their clinical experience, or if it breaks standards, then they don't feel like they have the responsibility to have to honor that choice and that patient's autonomy. So I'm going to give another vignette to sort of illustrate these differences. So I had two doctors, different hospitals, and I never asked about this specific situation, but I had two doctors from the same city that gave such parallel descriptions of the story, but with very different interpretations. So I'm going to share both of those, and they give us an opportunity to think about how differently doctors understand the role of patient autonomy in labor and delivery. So the first obstetrician says, another thing that we sort of see a lot, especially as a sort of cultural difference, is the willingness or not willingness to have a cesarean section. For instance, we have a doctor who cares for a lot of African patients, and they never want to be induced, they never want to have C-sections, and that's because they come from a culture where A, that doesn't happen and they're not used to highly medicalized care. And B, they're sort of used to a world in which not all babies do survive. And what happens because nature and God wants it to happen. And if they decline a cesarean section and their baby dies, that might be okay with them in a way that's very different than our sort of American mentality of like, well, we can save your baby. And that is an issue that has come up in my training several times. And it's very, very difficult. And again, that's where a physician's own sensitivity is important, because the truth is our primary responsibility is to the woman. And doing a surgery on someone without their consent is assault and not okay. So when she's referring to this physician's own sensitivity, you can interpret this as the value that she places in her commitment to patient autonomy, and honoring patient-centered care, right? So let me compare this to another obstetrician who has a different perspective. So this obstetrician, she says, we have a very high population from Somalia. The following pattern was very popular with the Somali patients, which is they would accept the evaluation, but they would not accept the intervention because they would explain it was Allah's will. And also they had to ask their men and their family for permission. So I accumulated lots of examples of this. There was another example where the baby was breech and she kept saying Allah's will. So then she came in labor and the baby was breech and one leg was out. And we would ask, can we do the cesarean? The leg is turning blue. And she would ask the men and they'd say no. And we had to get a court order. So a court order means the obstetrician summon a judge to the birth and legally force the woman without her consent to have a cesarean section. Here we have two very similar situations describing, patients who have given a very affirmative choice that they do not want the cesarean section. And in one case, a physician struggling with that difficult choice, but saying, hey, my ultimate responsibility is to honor the autonomy of the childbearing person. The other obstetrician saying, no, we're getting a court order and we're forcing her because I think she's making the wrong decision. So, what I find is that while standards of care are sometimes enforced through hospital policy or insurance policy, patient autonomy really is not enforced in any sort of institutionalized way. So when doctors are making what they often see as risky decisions to honor patient choice, this is because they feel it's the right thing to do. They have a sort of internal, intrinsic motivation to honor patient autonomy to do what they think is right. There's really not institutional pressure in the same way. If anything, there's institutional pressure to be following standards of care or to sort of cover their butt from malpractice lawsuits. And so there's a number of different kinds of these sort of coerced and forced interventions that emerged in my work, besides the extreme of a court order, right? But there's lots of other ways in which doctors sort of coerced childbearing people away from the decisions that they wanted towards either decisions that followed the physician's medical experience or standards of care. And this looked like things like not offering fully informed consent. So kind of saying, we have to do this, when really there are more options. They just aren't offering those options. Threats of more invasive interventions. If you don't do this, then you'll have to have this other thing that you don't want. Threatening that the baby could die or there's going to be a bad outcome for the baby. Getting the nurses, pediatricians, and other staff to sort of team up and bully the mom into a decision that she doesn't want, and then court-ordered interventions. It didn't come up in my research, but in other research, you also see threats of getting child protective services involved. So, when we think about traumatic births and obstetric violence, and these kind of stories where people are experiencing these coerced and forced interventions, my research sort of unpacks what's going on in the mind of the obstetrician in that moment, to be making it so they think that's the right decision, right? As they're kind of in their own heads weighing patient-centered care, standards of care, and their own perspective. And what I also want us to think about in this situation isn't just what's going on in the physician's head, but also the context in which they're making these decisions, and the way that the U.S. legal system is playing out in these situations is that it can be used to enforce medical authority over women's autonomy, right? And these court-ordered interventions that we see happen in the United States. Whereas people have a hard time finding legal counsel for cases of obstetric violence, especially when the baby is healthy. Malpractice lawsuits tend to happen when there is a medical complication, a poor outcome for the baby. But when the childbearing person has experienced obstetric violence, it can be hard for them to find a lawyer who's going to take that case. I do want to give a shout out to the Birth Rights Bar Association, which is a great advocacy resource for birth rights. But we know that people have had a hard time using the law to support their right to autonomy in birth. And in fact, in the United States, people don't have a constitutional right to childbirth decisions. People have a constitutional right to refuse unwanted medical treatment, but courts will and have override this right under truly extraordinary or compelling reasons, which have included the state's interest in protecting fetuses and children. So this would be the sort of justification we see when the law is used in a court-ordered cesarean or other court-ordered medical interventions. So what do we do with all this? First, I want to say I'm a big advocate of community birth and alternatives to hospital birth, and supporting midwives and a range of practice settings. But I also want to acknowledge that there are some people that have high-risk conditions where their only option is to birth with an obstetrician gynecologist in a hospital. So I do want to, and that's because that's where my research was based, offer some ideas of how we can improve birth in that context. Building institutional incentives for patient-centered care. As I mentioned, there's institutional incentives for following standards of care. We have a lack of institutional incentives for patient-centered care. I do want to acknowledge that culture change is possible. There were a couple obstetricians who worked in really special hospitals where there was a very strong focus on patient-centered care. Also happened to those places have much more of a midwifery model of care. And not all the OBs came in with that perspective. In fact, one of the people I interviewed in a hospital like that talked about coming out of residency from, this high risk, high intervention, very technocratic model of birth and getting hired at this hospital and being like, they're doing water birth, what? Like, this is crazy, and then after she had a number of experiences of this other way of practicing, went through a total transformation. And they were able, through a few leaders in this small hospital, to really change the culture and how they were practicing birth to be more patient-centered, baby-friendly, all of these positive things. So I do see that culture change is possible in some situations. Another way to improve hospital birth would be more holistic definitions of health and safety. So I mentioned this early on that, one of the OBs in one of my first quotes was just like, my job is just to produce a healthy baby. And when health is this very limited medical definition of what constitutes health for the childbearing person and the baby, we really miss out on so many social, psychological aspects of well-being. And, I know I'm preaching to the choir probably here about people who are aware of the harms of birth trauma. So expanding, educating, practitioners, OBs on expanding their definitions of what health and safety mean. A more robust legal defense for women who experience obstetric violence would help in our current context in the US. Patient education. When people understand the system and they understand their rights, they're in a better situation to advocate for their care. And malpractice reform could also alleviate some of the pressure that doctors feel in terms of feeling like following patient-centered care is legally risky for them. So I'm going to end my talk by transitioning to a quick pitch and description of my new research project. And I'm only in the proposal and grant application stage of this. But just in case there's anyone who I might be able to network with on this project and want to share, it's improving perinatal care in St. Lawrence County, which is in northern New York where I live. And this is a community-based applied advocacy research project where the goal of the research is really to improve perinatal care in my local community. So I'm using this is going to be a mixed method study, including a survey and in-depth interviews. And for the survey, I'm using some existing instruments. The Listening to Mothers survey, some folks might recognize from the United States. This was one of the first large national study of people's experiences of birth in the United States. But the Birth Lab in Canada has created some amazing indexes that focus on the things I think a lot of people in this conference would be interested in. They have a Mothers on Respect index, a Mothers Autonomy and Decision-Making scale, and a Mistreatment index. So if you're interested in obstetric violence and reproductive justice, these are great scales to check out. So I'm planning on using those, but also creating some of my own questions based on my specific geographical cultural context here in the North Country. So right now I'm working with stakeholders around the community to develop additional survey questions and interview topics. For instance, some of the things that have come up are rural geographic concerns, trauma, Indigenous perspectives, or the needs of people who struggle with substance use in the perinatal period. And my advocacy goals for the project are to build grassroots support with data, hard data. We don't have data on any of this stuff up here. To support community birth, to support a community doula program, to offer community reproductive justice education, to educate health and service providers in the county, and to expand our perinatal health services. So my contact is on this slide, diamondlaw@potsdam.edu. And the data that I presented today, I do have is based on a couple articles I've written. So if anybody wants to read those in more detail, you can look them up. They're both social science and medicine. And then I have an upcoming chapter in an anthropology book that's just not out yet. But I want to stop sharing so I can look at the Q&A because I think that there's at least one question there. Can you share some ideas you have for institutional incentives for patient-centered care? That's a really good question. I think one idea could be coming from hospital leadership. So, my understanding of, I had one of the OBs that I talked to who had a very strong commitment to patient autonomy, talked a lot about how their chair of their department talked to her and the rest of the OBs about how they should practice. And she's like, my chair stands by my decisions 110% to honor patient autonomy. I never have to question if following what a patient wants is going to get me in trouble with the institution, because they always say that, if you're doing what a patient wants, even if it goes against standards, I support you. I trust you to follow what your patient wants and honor patient autonomy. And I think that confident, that vote of confidence coming from hospital leadership can be one, small sort of institutional incentive to offer patient-centered care. Another thing is to collect better data on the quality of care people are practicing, and then have incentives from the institutional structure to reward that, or to acknowledge when things are not happening well, right? So, we have these quality surveys that some healthcare service providers offer, but what a lot of my obstetricians said is they have no idea what their patients thought about their care. They never get an opportunity to sort of debrief with their patients on what their patient's perspective was on how the labor and delivery went. I think so often there is this huge gap in communication that a patient might have felt totally disempowered and had moments that really frustrated them, where they were really disappointed, where they felt like they weren't getting the kind of care that they wanted. And that the doctor might be completely oblivious to that. So building better accountability structures or reporting structures where we have the opportunity to really collect feedback from patients on their experiences, and then having the leadership of the institution, review that and give feedback to their providers, and set expectations that, it's not okay if folks are consistently being reviewed that their patients are feeling disempowered. What are we going to do about this? Have this be part of performance review kind of things. So I think that would be one suggestion of an institutional incentive where we could do better to support patient-centered care. Are there any other questions?
Oh, it looks like there are a couple others. Wow.
Yes. So I am in contact with Sunday Smith, and she actually attended my most recent birth of my baby, who's now 2. But a shout out to Sunday if anybody's in the North Country. And I'm working with her to improve birth here in the North Country community. And so thank you for that suggestion. And Sunday was able to open a birth center. So, for folks who aren't from this area, we're in a very rural, low-income county. We've been having hospital closure after hospital closure for places that, used to offer labor and delivery. And we had, for a long time, like one home birth midwife who was covering an insane amount of miles to offer the only alternative for folks who didn't want a hospital birth, except for in the local indigenous community of Akwesasne, they have midwives collectives there as well. But for the non-native folks who wanted something other than the hospital, there really weren't any other options. And Sunday, about a year ago, a little over a year ago, was able to open a birth center where she's able to offer out-of-hospital midwifery care to a lot more folks. But we have growing demand, and I'd love to see more options of community birth open in our community. And someone else asked, have you encountered a hospital OB where there was a good model to redress obstetric iatrogenesis? I don't know off the top of my head. I need to think about this. I mean, I guess if we're thinking like harm caused by unnecessary intervention, I mean, there were some hospital labor and delivery units that functioned with more of a midwifery model of care, where midwives saw patients in pregnancy, and midwives were the primary people who worked on the labor and delivery floor and worked from a position that less intervention is better. And the OBs were only called in when there was a problem that needed their higher level scope of practice. Now, I only have the perspective from the physician, so I don't know from a patient's perspective, or I don't have data on like rates of interventions and morbidity and mortality of that hospital to be able to say how kind of accurate the OB's perspective was. But they seemed to think that they were doing a great job of, low C-section rates, low morbidity and mortality and just low rates of intervention in general, because they were really trying to make more of a hands-off midwifery model of care the model. And, a lot of OBs were very honest. They're like, hey, I'm trained as a surgeon. I'm not good at sitting on my hands. Like, I'm not good at labor watching. Like, I start wanting to do things because I'm trained to do things, and so some of them were very upfront about that. And they're like, if I'm not there, it's probably better. So unless they need me, and then they really need me, and then I'm really important to be there. Right. So, it was interesting to see that there were OBs that had that perspective. Certainly not all. I had some OBs who literally talked about midwives as if they were witches and were so uneducated about alternative models of care. It was frightening. But I would think maybe that kind of a model might be something that would answer that question about, unnecessary harm.
It looks like you have a fourth question. I had a question, but it looks like you have so many good questions that you can just answer these. I had a question. Here's a fourth one here.
Okay. We have a large military community, and the on-base hospital and insurance plan will only pay for hospital birth. What advice would you have for helping these women get more choice? Also, the military hospital does not have a NICU, so often babies are taken off base away from mom. Ugh, I hate these stories. To the community hospital NICU, and mom is not allowed to go, and she's not allowed to deliver in other hospitals. So I will say this is something we see in my community here. We're in a rural place. We don't have a NICU, and it absolutely baffles me that a person would deliver their baby and they would zoom off the baby to another hospital with a NICU while that woman is healing, coming out from a cesarean section, never gets to meet those babies or baby. And also then can't travel to the NICU because they might be in the hospital themselves. These situations just make me sick. And I feel like that just needs to be advocacy, that's what I'm going to try to do here, right? That's part of why I want to do this project on collecting data of people's experiences to be able to come to our healthcare systems and say, this is unacceptable. Look at the harm you're causing people. We have to be able to have childbearing people and their babies together. If we don't have a NICU, then we have to figure out how to transfer that mom to the hospital with the NICU. I think that hospitals just get stuck in their institutional routines, and unless someone's banging on their door, right? I'm really envisioning using my data to energize the community to hold protests and marches that we demand more. And I think that sometimes that's the kind of pressure that's going to get an institution to make change. And for the first part of that question, if there is a alternative, if you have a midwife in the community who's offering home birth, but the military folks can't get it paid for through their insurance, there might be ways to start a nonprofit that raises money to pay for home birth for folks who can't afford it through their insurance. I know we had something like that up here in my community because lots of insurances, even outside of a military base, have not been great about covering home birth. We have seen some positive change in this direction, and maybe there is some space for advocacy with the military insurance plan to be like, hey, you have to be equitable to other major insurance companies. You're serving our military, because I know, for instance, the health insurance that my school provides through New York State will now cover home birth. And some Blue Cross Blue Shield in different states are starting to also cover home birth. So I could see some advocacy on putting pressure on that insurance plan to make that change, and also maybe doing some local fundraising to try to cover the costs for an out-of-hospital birth. But I also think if there is a home birth midwife in your area, some folks simply don't know like how much cheaper it can be to birth with a midwife at home compared to a hospital, depending on insurance. So, an insurance in a hospital, depending on what they cover, it might still be thousands of dollars. And that's probably what the out-of-pocket fee would be for a midwife attended birth if you were just paying out of pocket. So, we need to work politically on access to community birth options across the world. But these are ways I see people kind of cobbling together resources and advocacy in the absence of large scale change.
Well, thank you. I wanted to I guess it's 4:59. So I actually had that exact situation that you talked about. I had twins, and one of them could have been born normally, one of them was breech actually. But I did have but actually I had my water broke like at week 27 or something. So week 31 they got infected, and I was in the hospital in Syracuse because I was living in Watertown, New York at the time. And then we moved down to I went down to Syracuse, and so I was like, it was a very medicalized birth already. It wasn't the kind of birth that I had thought of already, and I was okay with the C-section. I wanted to, to get them out. They had to get them out quickly anyway. So, but yeah, so I thought that was interesting. I just, if you could answer just one question, I know we'll go a little bit over time.
Sure.
Yeah, I was curious about, you mentioned, you've answered some of my questions. You've talked about differences in attitudes toward different, like the providers, depending on the patient's, nationality status, or to some extent race or cultural background. But I was wondering, did you find among the practitioners any difference? I don't know what your sample size, but was there a difference based on gender or based on the race of the obstetrician or the cultural background of the obstetrician? Did you notice anything there, or was it just more individuals than anything like that?
Yeah, this is a great question. And I did not have enough diversity in terms of race or ethnicity to be able to comment on that. But my sample size was 50, and it was split right down the middle between men and women physicians. And there was no difference. People often think that female OBs are going to somehow be more supportive of patient autonomy and be more patient-centered. And I did not find that at all. In fact,
that's interesting.
Some of the I would say worst stories of obstetric violence came from female OBs.
That's interesting. But so they were all people who would be constructed as white, you're of European descent, all your doctors?
They weren't all, but I just only had a very, small percentage of non-white. So okay. I don't feel like it was enough.
So it wasn't enough to be able to make it, could just be individual stuff. Yeah. Yeah. Oh, that's interesting. Well, I'd love to talk to you more about this, but it is 5:02, so I feel like I have to let you go. But thank you so much. I really, that was really, and you also expanded my thing, because I was thinking, it was interesting because I teach Tuskegee in my gender and race in the history of medicine in the United States. So that was really interesting when you said when the African American patients will say, "Are you sure?" And I was wondering, but actually one more thing, was there any understanding maybe that difference would come from things like Tuskegee, like the fact that African Americans have been used, when you talk to the doctors, do they have any broader sociological thing, maybe they don't trust as much because of this history, or was it just yeah, that's weird?
A couple did, but not by and large, not across the board. And as a medical sociologist, when I just interact with healthcare providers, I often ask what they know about these
Tuskegee,
and
or anything like that.
Or even the Sims and the history of obstetrics in the United States and some of this kind of stuff. And they basically explained that their cultural competency training is so minimal and very, very kind of stereotyped and generalized. And they really lack a deep historical understanding in the United States context of the kind of historic trauma that African-American and Indigenous communities have faced at the hands of healthcare providers. And I think that there is a huge space for education in that regard, that they have to work extra to earn trust from those communities
Yeah.
because of our history, you know.
And there's not that, you don't see that awareness among doctors.
No.
Okay, that they would have to do that. Wow.
A handful, a
Yeah.
small handful,
Small
but
handful, but not as general. Yeah. Well, thank you so much for that wonderful talk. And thank you for answering all the questions. Thank you for the attendees for asking these great questions. So have a wonderful evening. I hope maybe we'll have a chance to get together sometime or meet, since it sounds like our research it checks a little bit, and I'd love to hear more about what you're doing.
yeah, likewise, Connie, it would be fun to have a regional get together or something.
Yeah, it definitely would, if people who like study with gender and medicine or something. I think that would be
Yeah.
great. Okay, well, thank you so much.
Thank
Have
you.
a good day. Okay, I'm going to end the session for everybody, I think then.
Okay.
Okay. All right, bye.
Everybody.
Bye.